Spleen. Rupture of the spleen, one of the most frequently injured organ in the abdomen. Its injury causes severe blood loss. Spleen is normally small, hidden by ribs and protected by the thick abdominal muscles. Etiology. We have predisposing factors and types of trauma. Predisposing factors: splenic enlargement makes it more liable to trauma, and diseases of the spleen like malaria which make it friable. Types of trauma: blunt abdominal trauma or trauma to lower thoracic cage as in road traffic accidents and falling from a height. Penetrating trauma of gunshots or stabbing. Operative trauma occurs during an operation on adjacent viscera as during gastric or colonic surgery. Spontaneous rupture of the spleen is rare. Pathology. Types of splenic injury: subcapsular hematoma, small superficial tears, single or multiple, deep tear, single or multiple, avulsion of a pole of the spleen and complete pulping of the spleen, and finally, injury of the vascular pedicle, vessel avulsion or thrombosis. Complications: hemorrhage, intraperitoneal, retroperitoneal, or in the pleura if the injury involves the diaphragm. Splenic cyst may follow a perisplenic hematoma, associated other abdominal or thoracic injuries. Clinical picture: there are three clinical presentations: classical, fatal, and delayed. Classical rupture is the commonest presentation. The general manifestations are of internal hemorrhage. We have weak and rapid pulse, low blood pressure, dyspnea and increasing pallor. Abdominal examination: tenderness and rigidity in the left hypochondrium with shifting dullness which may be elicited. Then we have three special signs: Kerr's sign, Coulin's sign, and Balance's sign. Kerr's sign: referred pain in the left shoulder due to irritation of the diaphragm, especially if the patient is in the Trendelenburg position. Coulin's sign: brownish or bluish discoloration around the umbilicus, occurring in about 20% of people who have thin linea alba around the umbilicus through which blood can shine. Balance's sign: late and pathognomonic, shifting dullness on the right side due to free flow blood in the peritoneal cavity in the right flank, and fixed dullness on the left side due to presence of intraperitoneal clotted blood and retroperitoneal hematoma. Fatal type: the tear is deep or the pedicle is ruptured, so the hemorrhage is so massive that rapid death occurs. Small vessels in the spleen and sinusoidal lack muscle coats, so they don't constrict to stop the bleeding. Delayed rupture: the initial shock is followed by long lucid interval, may extend to a few days or weeks, after which the patient presents with internal hemorrhage. This delay of clinical presentation may be due to three reasons: subcapsular hematoma, which gradually enlarges and rupture, or omentum seals, perisplenic hematoma, then later it retracts, or a clot stops bleeding but it's later dislodged when the blood pressure rises or digested by enzymes from an injured pancreas. The three stages may be present: stage of shock, stage of recovery, this is a lucid interval due to arrest of the blood from the hypotension, or finally the stage of internal hemorrhage due to rise of blood pressure after resuscitation. If the patient is in severe shock, there is no need for investigations. The surgeon depends on clinical findings and proceeds for immediate laparotomy to stop bleeding. Investigations: radiological, abdominal ultrasound or CT scan, this is the most useful, diagnostic, accurate up to 90%, serial examinations to monitor hematoma size, plain X-ray, poor diagnostic, and may reveal fracture of one or more of the lower limbs. Laboratory: repeated blood picture, declining hemoglobin and hematocrit denote hemorrhage, instrumental peritoneal lavage to reveal bleeding. Splenic injury: it can be minor injury in a stable patient or unstable patient. If minor injury in a stable patient, conservative treatment by rest in bed, resuscitation, close follow-up for up to 7 to 10 days, while in unstable patients, urgent laparotomy after correction of hypovolemia. Then we go for splenectomy or preserve the spleen if possible. In children less than 15 years, every attempt should be made to preserve the spleen due to the vital role of the immune mechanism in this age. Spleen preservation can be done by suturing a small laceration, partial splenectomy, or compression of a lacerated spleen in a polyglactin or visceral mesh. Splenectomy is mandatory if there are deep lacerations, avulsion of the splenic pedicle. Post-splenectomy with 2 weeks triple vaccination against pneumococci, meningococci, and H. influenza type B to guard against severe infections. In children, this is repeated every 5 years until the age of 18, and for adults, antibody tests every 5 years to determine the need for revaccination. After conservative surgery, meticulous observation is necessary because the patient may rebleed. Functions of the spleen: they are divided into 3 parts: fetal erythropoiesis, sequestration of old blood cells, and defensive functions. Fetal erythropoiesis from the 5th to the 8th months of fetal life. This function doesn't continue in normal adults. If the bone marrow production of red cells becomes defective after birth, as in myelofibrosis, splenic erythropoiesis continues. Sequestration of all blood cells, aged and abnormal erythrocytes, abnormal granulocytes, normal and abnormal platelets, and cellular debris are cleared by the spleen. At normal conditions, platelets survive 10 days circulation. Third of the normal platelet pool is sequestrated in the spleen. In splenomegaly, up to 80% of platelets are sequestered in the spleen, and this may lead to thrombocytopenia. Defensive functions: macrophages phagocytose foreign substances such as bacteria, fungi, protozoa, and particulate matter. Plays an important role in proliferation of T and B lymphocytes. It helps in the production of various antibodies such as IgM, tuftin, stimulates phagocytosis by neutrophils, opsnin, binds to bacteria and fungi to make them more susceptible to phagocytosis, properdin, to fix complement to bacterial and fungal surface before phagocytosis, and interferon is an antiviral antibody. Infections of the spleen: acute abscess, rare condition occurring due to specific fever from typhoid or blood-borne from a distant septic lesion or during systemic pyemia. Treatment: percutaneous drainage under ultrasound or CT guidance. Splenectomy may be very difficult due to dense adhesions. Schistosomiasis of the spleen: etiology: infection by Schistosoma mansoni in 75% and Schistosoma hematobium in 25% of cases. Complications: susceptibility to injury, susceptibility to infarction, and hypersplenism. Clinical picture: manifestations of schistosomal splenomegaly: dragging pain if it's very large. If splenic infarction occurs, pain occurs due to peritoneal or diaphragmatic irritation. Splenic enlargement may cause secondary hypersplenism. Treatment: splenectomy is rarely needed. Only in hypersplenism, huge splenomegaly which is a burden to the patient, recurrent attacks of pain secondary to splenic infarctions. Causes of splenic enlargement in schistosomiasis. In early stages, it results from reticuloendothelial hyperplasia due to deposition of ova in the splenic radicals. With the advancement of hepatic fibrosis, chronic venous congestion occurs, leading to progressive enlargement of the spleen, which is a congestive splenomegaly. Gross picture: the spleen is enlarged and has a thick capsule. Perisplenitis may result in adhesions of the diaphragm. The splenic vessels are markedly enlarged and tortuous. Most of the complaints in patients with schistosomal hepatosplenomegaly are secondary to portal hypertension. Unlike liver cirrhosis, impairment of liver functions with schistosomiasis is a minor complaint. Hydatid disease may lead to formation of a single or multiple cysts of the spleen. Treatment: splenectomy. Malarial spleen incidence common in endemic areas. Gross picture: spleen may reach a huge size and it's soft. It acts as a reservoir for malaria parasites and every now and then causes an acute attack. Complications: malarial spleen is very liable to rupture because it's friable. Splenomegaly. Causes of splenomegaly divided into infections, blood diseases, metabolic collagen diseases, portal hypertension, cysts of the spleen, and tumors. Infections: bacterial such as typhoid, paratyphoid, tuberculosis, and abscess or syphilis, viral, infective mononucleosis and psittacosis, parasitic, schistosomiasis, protozoal, malaria, blood diseases, leukemia, myelofibrosis, hemolytic anemia, thrombocytopenia, polycythemia vera, metabolic causes, Gaucher's disease and porphyria, collagen diseases such as Filty syndrome and Still's disease, portal hypertension, cysts of the spleen, hydatid and blood cysts, tumors of the spleen. Causes of huge splenomegaly: thalassemia, myelofibrosis, malaria, portal hypertension, and finally Gaucher's disease. Clinical picture: intra-abdominal swelling in the left hypochondrium. It may descend downwards medially in the direction of the umbilical region. With inspiration, it moves downwards and medially. It has a sharp medial border. A notch is commonly felt, and the surface is usually smooth, nodular only in lymphoma. The fingers cannot be insinuated between the spleen and the costal margin, so the upper border cannot be reached. To differentiate from renal swelling, it's by Ballot-Mint test, and the splenic swelling doesn't fill the loin, and there's dullness on percussion for the splenomegaly. The normal spleen cannot be palpated clinically. If the spleen is palpable under the costal margin, it's enlarged at least 3 times its size. Enlargement of the spleen may reach below the level of the umbilicus or even down to the right iliac fossa. Hemolytic anemias of surgical interest, hemolytic anemias that are treated by splenectomy, such as hereditary spherocytosis, it's cured by splenectomy, some cases of thalassemia, less beneficial than in spherocytosis, and sickle cell anemia or the autoimmune type, which are rare cases. Sickle cell anemia, patients develop acute attacks if exposed to hypoxia. If they require surgery for any reason, there should be adequate oxygenation all through the operation. Tumors of the spleen, incidence, they are not common. There may be due to part of generalized reticuloendothelial affection as a lymphoma or leukemia, tumor which is confined to the spleen, such as benign tumors as lymphangioma and cavernous hemangioma, localized forms of lymphoma. Secondary tumors are rare, may be infiltrated by direct extension from carcinoma of the stomach or pancreas. Hemolytic anemias are divided into extracorpuscular and corpuscular. Extracorpuscular, acquired type, we have autoimmune hemolytic anemia, incompatibility, hemolytic transfusion reaction, and paroxysmal nocturnal hemoglobinuria. For the corpuscular or congenital type, they are divided into cell membrane defect as hereditary spherocytosis and hereditary elliptocytosis, hemoglobin defect as in thalassemia and sickle cell anemia, and enzymes defect such as G6PD deficiency and pyruvate kinase deficiency. Hereditary spherocytosis pathology, it's autosomal dominant, males equal to females in incidence, pathogenesis, a defect in the red cell membrane due to deficiency of certain protein. The cells become spherical, less deformable, and they are smaller. Instead of being biconvex discs, the spleen recognizes these blood cells as abnormal and destroys them. Complications, chronic leg ulcers may develop, which is rare. Gallstones, pigment stones in up to 60% of cases, they may occur under the age of 10. In hemolytic disorders, the reduced red blood cell survival is shown by measuring the disappearance of patients' radioactive red blood cells labeled with 51 chromium. The splenic role may be evaluated by determining the relative uptake of radioactivity by spleen and liver. Clinical picture of hereditary spherocytosis, type of the patient, infancy, early or maybe delayed. General, there is mild hemolytic jaundice associated with mild to moderate anemia, local, splenomegaly and hepatomegaly. Hemolytic crisis, which is precipitated by infection and presents with severe pallor, abdominal pain, fever, vomiting, and followed by jaundice. Investigations, hemoglobin level and red cell count is reduced. RBCs are small and biconvex microspherocytes. The reticulocytic count rises to 5 to 20%. Fragility test, this is characteristic. Hemolysis starts at 0.6%. Normally, hemolysis starts at 0.45% sodium chloride solution. Unconjugated bilirubin is elevated. Radioactive studies using chromium isotope 51 chromium that is bound to the patient's own RBCs reveals shortened half-life and increased radioactivity over the spleen. Abdominal ultrasound may reveal gallstones. If the patient have gallstones, cholecystectomy is simultaneously performed with splenectomy. Treatment, splenectomy is curative, although RBCs remain abnormal but their lifespan is increased. The best timing of this operation is at the age from 6 to 7 years, because after this age, the chance of developing gallstones is high, and before this age, there's risk of increased liability to infection due to loss of immune mechanism of the spleen. During surgery, search for accessory spleens, such as spleneculi. It's important to avoid recurrence of hemolytic anemias. Immune thrombocytopenic purpura, etiology. It was formerly known as idiopathic thrombocytopenic purpura. It's now known to be an autoimmune disease. Platelets are sensitized with autoantibody. Early sequestration occurs by reticuloendothelial cells, mainly the spleen and liver. Pathology, low platelet count, bone marrow contains normal or increased megakaryocytes, no systemic disease or intake of drugs which cause thrombocytopenia. The spleen is whether a source of antibody production or major destruction site for sensitized platelets. A huge spleen is against the diagnosis of ITP. Clinical picture, type of the patient, most commonly in children and young adult females. The course is intermittent in remissions and exacerbations. Symptoms, attacks of bleeding under the skin, petechiae and ecchymosis, or mucous membranes, or from an orifice, or nasal bleeding, urinary or GI bleeding, menorrhagia, common in affected young females. Signs, pallor, slight enlargement of the spleen, intracranial hemorrhage. It's rare, but it's the most frequent cause of death. Investigations, platelet number decreased, may drop to 30,000 per microliter. Red and white blood counts mildly diminished due to repeated hemorrhages. Bleeding time is prolonged up to 20 minutes, is normal from 2 to 5 minutes. Coagulation time is normal. Bone marrow contains large number of megakaryocytes with failure of budding. Treatment. In children, short courses of corticosteroids or immunoglobulins are usually followed by recovery, while in adults, the disease relapses are frequent. Splenectomy are indicated in persistent need for intake of the corticosteroids for more than 6 months to maintain platelets counts about 30,000 per microliter, or marked side effects of the corticosteroids. Differential diagnosis of thrombocytopenia, diminished production by bone marrow in patients with aplastic anemia or secondary to cancer chemotherapy. Increased platelet consumption in DIC, increased platelet destruction by the spleen in ITP, or secondary to drug intake or certain infections, or hypersplenism. Good response to corticosteroids predicts a good response to splenectomy. Hypersplenism definition: the spleen is overdoing its function of getting rid of old blood cells, and it also destroys young healthy blood cells, leading to pancytopenia. The bone marrow becomes hyperactive to compensate for the low blood cell counts. Clinical picture: frequent infections from low YBCs, petechiae and ecchymosis from low platelet count, and pallor and easy fatigability due to anemia from low RBCs. Investigations: blood picture reveals low counts of RBCs, leukocytes, and platelets with elevated reticulocytic count. One type of blood cells may be affected more than the others. Peripheral blood smear is devoid of any diagnostic features of leukemia or myeloproliferative disease. Bone marrow reveals pancellular hyperplasia. Confirmation is by injecting the patients or RBCs after being tagged with radioactive chromium-51 chromium and estimating the half-life of the RBCs. Patients with hypersplenism show diminished half-life of RBCs with elevated spleen-liver radioactivity ratio. Types of hypersplenism: we have primary and secondary. Primary hypersplenism, the idiopathic type. Etiology is not determined, but 51 chromium tagged RBCs sequestration studies indicate that spleen is the major site for phagocytosis, while secondary hypersplenism, pancytopenia, may arise from portal hypertension because portal hypertension leads to splenomegaly with vascular congestion, leading to destruction of the circulating cells within the spleen. Treatment of hypersplenism is splenectomy. So, splenectomy indications: injury of the spleen, hematological diseases such as hereditary spherocytosis, immunothrombocytopenic purpura, some patients with acquired hemolytic anemias, some patients with thalassemia who require frequent blood transfusions, particularly if they have acquired hemolytic antibodies, few patients with sickle cell anemia. Lymphomas, splenectomy performed to establish diagnosis and to reduce the dose of radio or chemotherapy. During radical surgery for stomach, esophagus, or pancreas. Hypersplenism, splenic cysts, and splenic abscess. Complications which are common to all operations, such as surgical site infection, reactionary hemorrhage if a ligature slips off an artery or a vein, atelectasis and pneumonia, as upper abdominal incisions are painful and restrict the depth of the respiration, deep vein thrombosis from hypercoagulability which follows splenectomy due to rising in platelet count. This thrombocytosis usually resolves within a month, and specific complications of the splenectomy are acute gastric dilatation, portal vein thrombosis due to post-splenectomy thrombocytosis, subphrenic hematoma or abscess. Pancreatic fistula may follow damage to the tail of the pancreas during mobilization of the splenic pedicle. This may be associated by left pleural effusion, peritoneal effusion, or abdominal wound dehiscence, subphrenic hematoma or abscess, and finally post-splenectomy bacterial infections, especially the encapsulated types, Streptococcus pneumonia, Neisseria meningitidis, and Hemophilia influenza type B. Risk is higher if splenectomy is done in childhood. A serious form is called overwhelming post-splenectomy infection, OPSI. This OPSI is fatal, so splenectomized persons should receive vaccines against pneumococci, which is called pneumovax, meningococci, and Haemophilus influenza type B. For elective splenectomy, the vaccines are taken 2 weeks before surgery and 2 weeks after. For emergency splenectomies, they are taken 2 weeks post-operatively. In children, vaccinations are repeated every 5 years until the age of 18, and for adults, there is antibody tests every 5 years to determine the need for revaccination. Patients are instructed that at first sign of febrile illness, antibiotics should be violently taken. And this concludes our part for the spleen.